We will now move forward discussing the recommendations for screening and treatment that we are launching today. And for this session, I am pleased to introduce Dr. Ian Askew, the Director of Sexual and Reproductive Health and Research at the World Health Organization, as well as the Director of the Special Research Program for Human Reproduction. A social scientist from the United Kingdom, Dr. Askew is a recognized expert in sexual and reproductive health and rights, both as a researcher and with extensive experience with health services implementation in low and middle income countries. Dr. Ian Askew, it's over to you.
Thank you very much indeed, Karen, for the kind invitation to speak. And greetings to everyone. It really is a huge pleasure and honor to be part of the launch of this important guidance. From WHO, we really appreciate the strong level of interest in the launch of this second edition of the WHO Guideline for Screening and Treatment of Cervical Precancer Lesions for Cervical Cancer Prevention, and feel confident that this level of interest in the launch of this document shows that it will be an important contribution to the cervical cancer elimination initiative globally. This effort has been a huge collaboration by many partners and experts, and our sincere thanks go out to all of them for contributing in many ways their expertise and time by participating in the guideline development group and in the external review group. Development of the guideline was implemented by two WHO departments, the Department of Sexual and Reproductive Health and Research and the Department of Global HIV, Hepatitis and Sexually Transmitted Infections. Recommendations in the guideline were drawn up using evidence inputs coordinated and supported by IARC and by the HRP Special Research Program in Human Reproduction. This collaboration across the two WHO departments has enabled the guideline to provide a coordinated set of recommendations for screening and treatment of both the general population of women and specific recommendations for women living with HIV. Reflecting this approach, the guideline will be presented by two colleagues, Dr. Nathalie Broutet from the SRH department and Dr. Shona Dalal, from the HHS department. Dr. Nathalie Broutet is a scientist in the SRH department. She is one of the world's leading experts on cervical cancer screening and treatment. And Nathalie also works on efforts to address disease outbreaks, including Ebola, and on sexually transmitted infections. Nathalie, over to you first, and then we will hear from Shona Dalal. Thank you.
Thank you, Ian, and thank you, colleagues. It's a great pleasure for me to be with you today and to share the new WHO recommendation for screening and treatment to prevent cervical cancer. So first, I'd like to come back to the importance. I'm sorry, I've got something. Thank you. So I'd like to come back to the importance of understanding the growing inequities in cervical cancer incidence rates across countries in the world, but also the growing inequities within countries that really show the importance of increasing access to screening and treatment to prevent cervical cancer. The member states have approved last year the global elimination strategy toward the elimination of cervical cancer and committed to eliminate this disease before the end of the century. However, in order to reach this objective, we really need to first reach the 2030 target on screening and on treatment of women screen positive. To this order, and in order to support the country to reach the 70-90 target, as we call them, we updated the guideline on screening and treatment from this pink guideline book to the teal one. So for developing this guideline, we set up a guideline development group comprised of 60 members representing all the WHO regions, including also healthcare provider, researchers, program manager, patient and women groups, advocacy groups, UN agency, and NGO. And the first task of this guideline development group was really to decide and to agree on which should be the recommendation that we focus on. And we agreed on age to start screening strategies, treatment or no treatment after screening test, follow-up, age to stop screening, and the screening interval. With regard to the strategy, we looked essentially at two strategies: screen and treat, where the treatment is based only on the results of a screening test, and the screen, triage, and treat strategy, in which the decision on treatment is based on a screening and a triage test. So we used, to do this recommendation, we used a wide range of evidence. Primary studies measuring important outcomes that the GDG had agreed on, the Guideline Development Group. This is really the major work of the IARC handbook. Published systematic review, diagnostic accuracy of tests, meta-analysis of data modeling, the effects and cost effectiveness, and also values, a survey of on values and preferences and on implementations. And we use really the benefits and harms. We really looked at the major benefits and harms for each of the interventions we have identified. In addition to the benefits and harms, we really looked at the certainty in evidence, the value placed on benefits and harms, the cost of the intervention, acceptability, the impact on equity, and the feasibility and sustainability. So it's all this information that led us to the recommendations. So altogether, we have 24 recommendations. And for both populations, the general population of women and women living with HIV. These are the two major summary recommendations. For the general population of women, we recommend screen and treat or screen, triage, and treat approach. With HPV DNA as primary screening test, starting at age 30, and with a screening interval of every 5 to 10 years. For women living with HIV, we recommend only screen, triage, and treat with HPV DNA as primary screening test, starting at age 25 and screening interval every 3 to 5 years. And with these recommendations, we really encourage countries to move and to transition from a primary screening test such as cytology or VIA toward the use of high-performance alternative tests as primary screening tests such as HPV DNA testing, in the screen and treat approach, except for women living with HIV, or in a screen, triage, and treat approach, where the triage can be HPV genotyping for the time being 16-18, VIA, cytology, or colposcopy. So this is also an interesting way of using this primary screening test in triage tests rather than primary ones. We also recommend self-collected sample when HPV DNA testing is provided. And we recommend to stop screening after the age 50 and after 2 consecutive negative screening results for both populations, the general population of women and women living with HIV. The age priorities for the general population of women should be aged from 30 to 49 years of age, and for women living with HIV, from 25 to 49 years of age. And for both populations, women between 6 and 25 years of age should be screened and prioritized if they've never been screened in their life. So I'd like to share with you some of the evidence we use to make these recommendations. First, when we compare HPV to VIA or cytology in the general population of women, you see in this blue box that HPV is here, prevents more precancer and cancer and saves more life than VIA or cytology-based screening. In addition, there are fewer treatment and preterm deliveries with HPV or cytology, however, than with the VIA, but there are higher costs associated to cytology that you can see here. So we recommend HPV rather than VIA or cytology. When we compare HPV alone versus HPV and triage for the general population of women, we can see that both strategies prevent cancer and save lives. And equally, there are similar number of treatments and preterm deliveries and cost when we compare both strategies. Therefore, we recommend both strategies for the general population of women. For women living with HIV, when we compare HPV to VIA or cytology, we can see that HPV here prevents more precancer and cancer and saves more lives than VIA or cytology. In addition, HPV and cytology reduce treatments more than VIA, but there are also greater costs associated to cytology. When we compare HPV alone on HPV with triage with cytology in women living with HIV, we can see that HPV-based testing without or with triage prevents more cancer and saves more lives than cytology-based screening. The treatment, HPV with triage and cytology reduce treatment by half. Costs are similar with or without triage, but there are also greater costs associated with cytology. And therefore, for women living with HIV, we recommend HPV with triage rather than HPV alone or VIA or cytology. With regard to screening interval, we looked at cost effectiveness through modeling work. And we used the cost on the health-adjusted life years for the general population of women, and we extrapolated for women living with HIV. So here, this dark line is the line where screening becomes cost effective. And you can see that some intervention, the price is higher. Then the choice is really depend on the capacity of country program to pay for such intervention. So when we look at screening interval of twice per lifetime or every 10 years or every 5 years, you can see that the cost increase when programs screen more often, which makes sense, right? And when we looked at HPV alone here, HPV with triage every 5 years, we can see that it's on the frontier of cost effectiveness. There's also the case for HPV alone or with triage when we screen every 10 years. And also the same when we use HPV alone or HPV with triage twice in a lifetime. All these strategies are on the frontier of cost effectiveness. However, when we look at VIA and cytology, they are not on the frontier of cost effectiveness. And therefore, for the general population of women, we have recommended 5 to 10 years screening interval and 3 to 5 years screening interval for women living with HIV. I'd like to come back also on the price that we use in this model to look at cost effectiveness. And we use the price that has already been negotiated for some countries. So this is a realistic price that we use in the modeling work so that the program can be cost effective. And we use the price of $8 for HPV.
Recording in progress.
Country or even given a context in a country. We need to increase quality and coverage of service delivery, in particular strengthening patient retention and linkage to treatment. We cannot start screening program without offering treatment to women who screen positive. Also, we need to have sufficient affordable supply of screen and treat technology and products. And WHO and partners really will work on that, on prompt certification of new products and price reduction strategy, of which, this $8 that we were discussing before are part of. And we will monitor progress, as Leanne was mentioning before. So just to finish, I wanted to remind you some of the WHO guidance available to support introduction and scale-up of screening and treatment guidelines. First, we have on the left-hand side the how-to guidance on how to introduce HPV tests in the cervical cancer prevention program. The second one is WHO technical guidance specification of medical devices, very useful for program manager to procure the material for the program. And then a policy brief on the post-market surveillance in cervical cancer program. And finally, a toolkit for monitoring cervical cancer program. So I'd like to thank my colleagues that have been working nights and days on this guideline, and the guideline development group members, the WHO Secretariat. And this is all the logo of our partner that supported the development of the guideline. And on the right-hand side, some of the donors that are also supporting our work. Thank you very much.
And thank you, Nathalie, very much indeed for a very clear description of the key elements in the guideline. As I'm sure everyone can appreciate, these guidelines have drawn from a huge amount of evidence, very well brought together, and the recommendations themselves, though, are very clear. And I think there'll be a huge help to the field going forwards. To follow on from this, we're going to be hearing from Dr. Shona Dalal. Dr. Shona Dalal is an epidemiologist and surveillance lead in the Department of Global HIV, Hepatitis and STI programs. Shona also leads the department's work on HIV and cervical cancer, and will be presenting on the implications of these recommendations for addressing the issues around cervical cancer amongst women living with HIV. So Shona, over to you.
I will now talk about the features of the cervical cancer screening and treatment guidelines and recommendations as they relate to women living with HIV. We know that cervical cancer and HIV are intricately linked. Women and girls living with HIV have a higher risk of getting HPV infection, lower chances of clearing the infection, faster progression from infection to cancer, lower regression of precancer lesions, and higher recurrence following treatment. They also have a younger age at presentation. Our goals at WHO are to better understand this relationship, to develop guidance related to cervical cancer and HIV, and to support women-centered program integration and the expansion of coverage. Last year, WHO released the first global estimates of the burden of cervical cancer attributable to HIV. It was based on a systematic review and meta-analysis of 24 studies that showed that the risk for cervical cancer was 6 times higher for women living with HIV than women without HIV. Using that relative risk, we calculated the population attributable fraction, and this map shows the stark global disparities in cervical cancer burden and HIV. In areas with high HIV prevalence, the fraction of cervical cancer attributable to HIV is high and is greater than or equal to 40% in 9 countries in Southern Africa. This is compared to less than 5% in 127 countries with lower HIV prevalence. As part of the WHO Cervical Cancer Elimination Modeling Consortium, 3 dynamic models calibrated to South African data simulated HIV and HPV transmission and cervical cancer incidence. And the goal was to estimate the potential for eliminating cervical cancer in South Africa, a country with a very high HIV prevalence. All 3 models show that cervical cancer elimination is possible in South Africa within the next century using WHO's recommended strategy. That is the elimination is the faint gray horizontal line across the top. Each model here is represented by a different colored line. However, it will be more difficult to achieve elimination for women living with HIV. With extended vaccination and more frequent screening and treatment among women living with HIV, and these are the dotted lines seen in the graph, the benefits accrue earlier with the largest impact due to the screening and treatment. This month in July, we are releasing 2 important WHO guidelines. The first are the screening and treatment guidelines, which we are discussing today, which talk about the age of screening initiation, the intervals of cervical cancer screening, and the optimal algorithms for screening and treatment. Just to note here that there were very limited data for multiple testing and treatment algorithms in women living with HIV. And so we relied on modeling of approximately 30 scenarios with differing screening tests and treatment options. We're also releasing consolidated HIV guidelines this month that focus on clinical services as well as service delivery. And it's here where we're focused on the integration and linking of services between cervical cancer screening and HIV services, because the over 14 million women on antiretrovirals provide an opportunity for screening and treatment that we should not miss. As Nathalie has already mentioned, there are differences in the recommendations for women in the general population and women living with HIV. I'll go into the ones on HIV in a little bit more detail. So similar to the women in the general population, HPV DNA testing is recommended as the primary screening test for women living with HIV. However, in the remarks, it's noted that until HPV DNA testing is operational, existing programs with quality assured cytology as the primary screening test should be continued. However, programs using VIA should transition rapidly because of the challenges with quality assurance. And we know that in many countries with high HIV burden, the primary test that's being used is VIA. For triage tests, the benefits, harms, and programmatic costs of triage options are similar, and therefore the choice of triage method will be dependent on the country context, feasibility, training, and resources available. In terms of age, WHO suggests starting cervical cancer screening at the age of 25 among women living with HIV. Now, previous WHO recommendations were to screen women living with HIV as soon as they were diagnosed with HIV if they were past sexual debut. However, there's low certainty evidence that there are small numbers of women living with HIV who have cervical cancer before the age of 25. Because there were few studies in the published literature with information on age or had comparable age categories, we put out an open call for data. A number of studies and programs implementing cervical cancer screening in women living with HIV generously shared their data with us. We were able to pool 8 of these for a total of over 12,000 women living with HIV. This summary graph shows the prevalence of histologically confirmed cervical precancer and cancer among women living with HIV, and where cervical intraepithelial neoplasia 2 and 3, a precancer condition shown here in blue, was seen very infrequently in women below the age of 25. In red are the negative tests. And so you can see the sharp increase between the ages of 25 to 29. In terms of screening interval, WHO suggests a regular screening interval of every 3 to 5 years when using HPV DNA testing and every 3 years with VIA or cytology. Women living with HIV need to be retested more frequently after a positive screening test and after treatment, which is about 12 months after. And once a decision is made to treat a woman, it's good practice to treat them as soon as possible within 6 months unless she is pregnant. As part of our review of the values and preferences of women and providers to inform the guidelines, it was noted that there were low levels of knowledge on cervical cancer, its association with HPV and HIV, and the ability to prevent and treat it. Encouragingly, there was high acceptability of different screening approaches and a preference for prompt treatment through either a single or multi-visit approach. In one online global survey that we conducted, some women reported they may have difficulties in returning for follow-up, and so this is something we need to keep an eye on. There was also a clear request for better counseling, patient education, and choices for screening and treatment. Our next steps will be to support ministries in adopting these guidelines to increase country-level impact and reduce cervical cancer incidence and mortality. We also want to facilitate the bidirectional integration of HIV and cervical cancer services and further strengthen links with the community and involve the community of women in all aspects of program development. And finally, we really hope to be able to address the remaining knowledge gaps in this area, particularly on HIV and cervical cancer with implementation science. We have many people to thank, including those who helped develop these guidelines, the Guideline Development Group, and our funders for the HIV sections, WHO, USAID, and USAID. Thank you.
Well, thank you very much indeed, Shana. And that concludes the detailed presentations from the 2 lead authors. And I'm sure they'll be happy to answer any questions if you have to put them in the chat or the Q&A function to go with this. So with that, I'll hand back to Karen for the next part of the session. Thank you, Karen.
Thank you so much, Dr. Askew, for sharing the screening and treatment recommendations to prevent cervical cancer session. And thank you to Drs. Nathalie Broutet and Shona Dalal for the presentations.